Hi, good evening, everyone. So I'm going to take you through the cardiology section for the INI SI. You just have SS for 7 days left, and I'm going to take you also through the Mini QRP as well. So what we'll do is that I'll take you through important topics that we need to actually go through at the end, but I'm also going to give you the strategy that one must follow so that you can actually maximize uh, your output for the revision session as well. So, 7 days strategy, what you can do, I think what you've done over last 6 months or 1 year is something that's going to stay with you. I'm sure, have given enough of hard work, but I think these 7 days matter most. It is said that what you do in those last 24 hours are the most crucial one. On top of that is the last week, and also, very importantly, what you've done over the last 1 year in the preparation strategy. But when you're prepared almost equally, the quick, crisp recall over last 7 days is what going to matter. If you try to read something new, it's going to be very difficult. And what you've read, and then if you practice a test session, that's what's going to help you the most. So I'm going to take you through the strategy that we do, that I followed for so many years. Something that so they say it's a 5M strategy: management of time, prioritization, active learning, in between regular breaks, and practice test. So this is a strategy that we all must adopt. You must have what I call a reverse timetable. Reverse timetable is what you need to do on the last day, is something that's pure rote memory based. Those factual questions which don't have a logic or conceptual understanding is something that you need to remember and practice on the last day. Time management is so important, not just in the exam hall, but is also important when you're preparing for the exams in last 7 days. Every hour, every minute matters. When you are now trying to revise, you need to have the speed that you're going to adopt, even when you're revising the concept in the same fashion as you would revise otherwise in the exam, or for that matter, how you're going to attempt in the exam. So, what I'm going to do is take you through the important concepts that I believe are in terms of time management. You need to prioritize. That's the second aspect. Well, how do you prioritize? I mean, if you are ending up doing acute coronary syndromes for next 7 days, it's not going to yield, because that's another important concept. What is a high yield topic? It's a very important topic, but if you have 400 pages and you get four questions versus say you have cardiac tumors, 4 pages and one question, your yield is more for cardiac tumors than for acute coronary syndrome. It doesn't in any way mean that ACS is not important, but that's not going to get you the input to output ratio in the fashion that you would desire. Also, active learning and passive learning. Passive learning is when you're just listening to videos. You must listen to videos during your initial preparation strategy, but once now you engage in the last moment, it is when you need your cerebral cortices to be activated. You need them in a fashion that you would be applying them in your examination hall. That kind of a learning where your active involvement in the learning is there, that would include practice tests. So if you do more QRPs, more questions, more revisions, more question bank questions, questions and concepts, notes, etc., whatever you have earmarked for last moment, that active learning is something required. Listening to a passive mode of learning, just videos, audios, or self-recorded sessions, are probably not the right strategy in the last moment, unless you're looking to a QRP session, quick revision session, where you are actually trying to solve the questions and you're actively involved in that learning. Of course, every 3 hours, they say the memory span of a human brain ranges from 8 minutes. Sorry, it ranges from 8 minutes to couple of, if you're very focused, to 30 minutes. So between 8 minutes to 30 minutes, you will probably need a break. And that's why between this range, you need to improve upon and take breaks. But you can't afford to, because if you take those many breaks every 30 minutes, you will not be able to practice that in the exam session. So what you need to do is give 3 hours of one stretch and then take maybe a 5-10 minutes break. Take those breaks, just walk around, exercise a bit, have a cup of coffee or a tea that you want, and then come back and again give another 3 hours slot, because that's what you need to train your brain of sitting at a stretch for 3 hours in an active mode. And very important, make the environment, as they say, of your exam when you're doing mock test like that you'd expect in the examination hall. So if no fans, and in summer we usually say in a hot environment where there is hardly poorly functioning air conditioner or just a fan, and at the same time, the time of exam that is expected, at that time that you appear for a mock test. And that strategy is something that I often call as the 5 M's of the strategy. So, what are your resources? Let's go back and dissect. So, 5 M's of management, as we all know: man, machine, material, methods, and money. I think we've already created resources. You have a lot of resources to look into. You have QBank, you have test series, PYQs, QRPs, diagram table flowcharts, your notes that you've prepared, and some of the QRP videos. This is what you are going to touch upon. Don't start upon trying to finish whole Harrison or whole Brunwald and last 7 days in one go. It's going to be very difficult. Even if you do, the amount of recall and amount of questions that you will attempt or amount of material that you will revise at multiple times will not be there. So if you were to ask, I think there are two ways to do it. If I was to decide one of the two strategies, one strategy would be to do two revision strategy. Other strategy would be just one revision strategy. I would stick to two revision strategy where you do 5 days plus 2 days, or maybe 4 days plus 3 days. Why? Because you want to be in a state of mind when you're entering examination hall that you have gone through almost everything last within 2 days. And that kind of a frame of mind is going to give you a very positive impact when you appear for the exam. So I usually advise 5 plus 2. A lot of you may feel that it's very difficult. So you can still in last 7 days stick to one revision. It's pretty perfectly fine. So what resources you have? You have a question bank. You can't end up solving whole of the question bank. What you can do is take a topic that you're doing on the day. I'm going to give you a sample, and you need not stick to that timetable, but I'm going to give you a sample timetable that you can stick to and try to look as to whether you can do that kind of a strategy of adopting the Q bank and the topics or not. It's your call. Other thing is to do a lot of test series. If you have, you can revisit, make a note. You've already made notes of mistakes that you've already done. Go to previous year question. That's the very important yield that you will have. A lot of times you get ranging from 2 to 3 questions to almost 10 to 15 questions from previous year. It often changes, but if you have a collection of say 3 to 5 years, very likely you'll end up getting 10 to 15 questions from the Q bank of the previous year question bank. Quick revision. If you have videos, go through it. I'm going to give you a mini QRP today. It's not a time to give you an exhaustive QRP. There are QRP videos, quick revision videos that are there already in the app. You can go through them. I've revised in 2 or 3 lectures last year, the last two last year. But today I'm going to give you a mini QRP where I'm going to take you through important topics pretty quickly. Try to go, as a lot of people were asking in the WhatsApp group, sir, if we can get the diagram table flowcharts in a PDF format. I think, why do you want to do that? Instead of that PDF of diagram table flowcharts, just open the book and scroll through diagram table flowchart. That gives you a better confidence that you've actually gone through that chapter, even though you're just looking at diagram table flowcharts. And the other advantage of it would be when you're going through diagram table flowcharts, and if there is some doubt that you have, you can immediately refer to it in the text itself. So go through diagram table flowcharts from the book, not from just a PDF of just combined nutshell of these. If you think that's going to save you time and that's your strategy, it's fine enough, but that's what I would do it through the book and then simultaneously go through the pages. It also gives you confidence that you've actually finished the chapter. If you have prepared notes, fine. If you have not prepared and you have notes from your seniors which you have never gone through, don't go through them now. This is not the time to start something new or afresh and go through QRP videos. So these are the resources that we are going to utilize. This is the way we probably can maximize our input and approach. So as I told you, the most important thing is to adopt a strategy, which I often believe is something that you can do, is reverse revision strategy. What it is, the memory-based questions. The rote memory-based questions where there is nothing but rectification of the concept and which you think is tough. And if you were not to look into those points at the last day of the prior to exam, you will not be able to recall. Keep those topics, make a list of those topics to be and revised and have a look at them on the last day, apart from the other things that I'm going to tell you on the day prior to the exam. Also, when you're trying to devise a reverse strategy of revision, you will do conceptual, logic based topics or questions, that topics first, which means, on the reverse day, which we say from today, if you're starting, so day 1, 2, and 3, probably I'll do topics where the concepts is all that matters, probably acute coronary syndrome, heart failure, topics like arrhythmia, where there is more of logic, concepts, etc. and what. When you have to look at genetic mutations, you have to remember names, number, loci, etc., epidemiology, percentages. That is something that you may forget by the end of 7 days. Those topics you keep for day 5 and 7. So 5 to 7. That this is what you do. Conceptuals you do in the initial part, 1 to 4 days, and you do memory based questions in the end, or topics in the end. So you identify where you, some people may have arrhythmia as something purely logical, while others would like to remember as to differentiating a supra valve RVO TVT versus infravalvular RVO TVT. You're not able to remember and you have actually mugged up the concept as to how to differentiate. You can actually call it maybe a rote memory based. That's how you, if you want to remember. As I told you, very important aspect is high impact versus high yield. And I've given you a classic example. High impact topic is acute coronary syndrome, heart failure. These are topics that will have definitely a couple of questions coming from it. But what are the number of pages that you need to read for them? You need to read something like 400 pages for probably 4 or 5 questions that may come from Brunwald. 400 pages of Brunwald and you get 4 or 5 questions. Compare this with a high yield topic, which I often call a simple way of counting as a number. If you have number of questions which are, sorry, there are a couple of questions that are going to be asked from, say, tumors. So you get only one question, but how many pages you need to read? It's just 4 pages. So 4 pages for one question and 100 pages for one question in ACS. So that's a problem. That's a problem. I mean, you end up reading ACS all the time, and number of pages and time that you've actually spent on, you get just 4 marks of worth it on reading 100 pages versus just 4 pages that you need for probably acute tumor. So, or say cardio oncology. So similar high yield topics is what you need to focus now. I'm not saying don't focus on ACS or heart failure. You'll get some questions from that, but this is the time when you should consolidate on small topics. For example, preoperative assessment in a cardiac patient. For example, pregnancy. These are the topics you'll always get one or the other question. Anesthesia in a patient with cardiovascular disorder. Uh, One or the other questions don't definitely come, and these are like 4 or 5 pages that you need to read. 12 pages done and 3 questions are there. These are high yield topics. Also, what you need to do is give yourself tests every day. For next 7 days, when you're doing a Q bank, you may actually not be doing a random pre-existing tests per se. You may just be doing, okay, today I'm going to do acute coronary syndrome only in my test. But then sit as if it's an exam on acute coronary syndrome, sit for 3 hours and attempt the questions as expected in the time, space, and method of attempting those questions should be what you're going to adopt your strategy of attempting the questions in the exam. That's how you should probably follow. So let's move to what are the important topics. So in Harrison's versus Brunwald's, Harrison, we know that you need to look at the ischemic heart disease, heart failure, valvular heart disease, arrhythmia, cardiomyopathy, pericardial disease, pulmonary hypertension, core P, hypertension, congenital heart, imaging, sudden death, aortic syndrome, rheumatic fever. These are the topics that are there, which are important. Same with the Brunwald's. When you look again, these topics pretty much match, but they are more in detail. You probably need to know what aspects. You can take a picture of the slide if you want to take a snap of this video. as to what are the aspects that you might need, and there is good amount of overlap between the two. So even if you have prepared only Harrison, don't be worried. If you know, for example, in pulmonary hypertension, the classification and the latest treatment, I think you're done with the most of the strategies that you probably need to adopt here. And if same way, if you're looking at the algorithms in hypertension and secondary hypertension workup, those are the important aspects that you need to know. So if you know what is important and there is a good amount of overlap between Brunwald's and Harrison, don't worry which book of the two you have already prepared. There is no time now left to go and start visiting other book for that topic. Whichever book you prepared, whatever topic, stick to that. So this is a rough template that I can give you, or say I was planning to give you 10-day template, then I thought I'll give you 7-day template. So what we can do is look at maybe conceptual based topics like arrhythmia. I feel arrhythmia is a conceptual topic. If you know arrhythmias by a concept, then probably you will understand and remember them. Same is the case with coronary artery disease and heart failure, because this is what you probably practiced all throughout your residency. So these are the topics that you pick up early. So you need to do a high these kind of high volume, high level concept, clinical concepts that you face day in and out. You may not have seen Brugada in your residency at all, but you would have surely seen a lot of patients with CAD, heart failure, and arrhythmia. And that's why if you do these kind of topics early, you will, I'm sure, are going to remember those clinical questions if they are asked ever, or for that matter, a question or MCQ that's asked based on these topics. They are going to be more of your judgment based, your conceptual based, which can easily be tackled. So you do them first. Practice the question bank of the same. Do their PYs. So there are two ways. Do the topic, do the questions. Do the topic, do the questions. When I say do the topics, I mean just read the highlighted points, go through the diagram table flowcharts of that topic in the book, and do their MCQs after closing out on that topic. So you can do either simultaneously on 2 days. I mean, CAD you do in the morning, you prepare, go through the diagram table flowcharts, and then give the exam in the afternoon if that's what is anticipated, and then heart failure in the evening and give its exam at night. Same way you can do the next day for arrhythmia. So 2 days you need to finish these two topics. Same way you can do valvular heart disease, congenital heart disease, pericardial disease, cardiomyopathies, infective endocarditis. This finishes primarily all the conceptual topics that you need to do. These topics you can also stick to along with the on fourth day with image-based question apart from the Q bank and other sources, because one or the other time these are the images that are asked, either X-ray, ECG, echo, or a cath procedure or an angiogram, which are asked. So by first 4 days you should be finished with the high impact topics, not high yield topics. You should come to high yield topics as you go in the later part. So then you need to revise topics like hypertension, pulmonary hypertension, and vascular topics, structural interventions like mitral clip, images of that. And you need to give mock tests, which simulates your full exam time, focused on the review based topic. Always prepare super high yield, quick sheet, and rapid fire oral visual based revision, recalling high tables, algorithms, summary boxes from whichever book you've read. Both best if you can't do both, because there is a lot of duplication. Actually, new edition of Harrison has a lot of tables and diagrams and flowcharts from Brunwald because the authors are same, and the publisher also is the same. So a lot of that is common. And if you're doing from one book, it's pretty fine that you don't do the other book if you're doing New Harrison. So that's the strategy. If there are any questions, you can actually put that into the chat box, and I'll try to in the live chat box answer them. And let's move to, in the meanwhile, to the mini QRP. I wanted to do a quick revision. Very often, one or the other question. So let's do a rapid fire 50 to 60 concepts, and some of those are very important in terms of exam. So I'm going to take you through those topics pretty quickly. Remember, cyanosis can be central, peripheral, differential, reverse differential, and mixed. So mixed cyanosis, though it's not mentioned in table here, it's going to be to a huge extent in diagnosis, as it is mentioned in Harrison, is in mitral stenosis. The mechanism of the same is because of the occurrence of peripheral vasoconstriction causing cyanosis of tip and lobule, while congestion causes malar flush or mitral paces, as we know, and that is together, and the hypoxia that you get at the tip of the tongue and the lung congestion also because of hypoxia you get central cyanosis. So pulmonary edema leading to central cyanosis, peripheral vasoconstriction leading to peripheral cyanosis. So mitral stenosis is one condition where you get both peripheral as well as central cyanosis. This is given in older edition of Brunwald, just in case this question pops up. So Central cyanosis, we know from CHT, heart failure and lung disease. Peripheral is because of the perfusion issues. Differential and reverse differential is usually asked, and you should remember differential cyanosis you get in PDA with reversal of shunt, and DTGA is where you get reverse differential cyanosis. Next point to remember, very often asked, is about X wave, very often a very vital topic. Absent, you get in atrial fibrillation. Also, TR will obliterate the same, RV dysfunction will also obliterate the same, while prominent X descent happens in cardiac tamponade. So remember X descent versus Y descent. Y usually goes with constriction, while X goes with tamponade. That's how you remember by differentiating the two terminologies and two conditions and learning by contrast, as I say. So X descent in tamponade, Y descent in constriction. I'm not going to go into the mechanisms of it. You know that probably pretty well. Abnormal V waves you get in TR, where you have RV failure, ASD, MR, Garbode, and CHF. While it's diminished, LNCC sign is giant V waves. Also, sometimes you call them S wave when you have obliteration of X, and then you have on top of that a positive S wave, which again together becomes what's called as giant V wave called NC sign. Uh, Various types of pulse. Anacrotic pulse you get in aortic stenosis. You may be given an image of the same sometimes, which may be asked. Remember, differentiation between moderate AR and HOCM bisparience is spike and dome pattern. So, if you get spike and dome pattern of a bifid, it's HOCM, while bifid is all that you will get in systolic. That's where you get it in moderate AS with AR. Water hammer or Corrigan's pulse is a rapid distal runoff, which you get in anemia, beriberi, thyrotoxicosis, AR, AV fistula, etc. Diacrotic pulse basically represents conditions like fever with enteric fever, etc., congestive heart failure. Remember, whenever a pulse is appreciable, it's more than 50% of the other pulse. Usually the pulse pressure here in diacrotic pulse, that's where it becomes prominent. Parvus is tartar, slow rising, late peaking pulse is a classic characteristics of aortic stenosis. Alternate strong and weak pulse are seen in pulsus alternans. AS with LV dysfunction can also manifest it. This is one of the common questions that is asked. Aortic stenosis, what are the pulses that may not be seen, etc. But very often, if the one of the option is given pulsus alternans, remember pulsar alternans in a patient with aortic stenosis with LV dysfunction can give rise to pulsus alternans. The other options are, of course, anacrotic pulse, pulsus bisvariance in presence of AR, and pulsus alternans in patient with AS with LV dysfunction. You can also get pulses parvus and tarda. So these are the four characteristics of pulse. But if all these four options are given, remember pulses bisvariance is seen predominantly in AR, not so much in AS, and hence that would be the odd one out. Pulsus paradoxus is nothing but exacerbation of fall in inspiratory pressure, and you've seen used classically in patients with pericardial effusion. Pseudoparadox you get in COPD. It can also happen in marked obesity, obstructive sleep apnea, etc. Pulsus cellar and tardus are known to occur in AR and AS respectively. The next question is splitting. Remember, electrical event and mechanical event. You get wide fixed split in ASD. The wide mechanism, I've already discussed a lot of times. The mechanism is increased pulmonary blood flow leads to delayed P2. Also, there is presence of RBBB, which also leads to A2P2 bit widened up, and increased hangout interval. You should remember this concept of hangout interval. It's important in late P2 occurrence in patients with atrial septal defect. The Why is it fixed? Because the shunt is balanced out in form of respiratory changes that happen. Expiratory splitting with inspiratory increase, you may get an RBBB and idiopathic PA dilatation. Paradoxical split, that is LBBB, you get in patients either because of electrical activity or mechanical causes. Electrically, the left beat would be slow and left beat would be delayed in patients with LBBB. So left bundle is not getting electrical supply. It's the right which comes through the right bundle first. And in presence of LBBB, the left side will then be depolarized and hence A2 will occur later in presence of LBBB. And the aortic stenosis, again, the cardiac output is maintained for long duration, and that's why you may have late closure of aortic valve and A2 may be delayed. A closed fixed split can happen in pulmonary arterial hypertension. Very often, one or the other ECG is asked, sometimes with clinical history. A lot of times, it's been asked in clinical setting in form of tricyclic overdose. There is a clinical question that's described as a poisoning, and the ECG shown is this much, pretty much matching the ECG here. And this is from both the textbooks, where it is shown that the widening of the QRS, the tolerance of T waves, QT prolongation, STT changes, tachycardia, which is a feature of tricyclic overdose. So there is a clinical question on that. Also, you may be asked subarachnoid hemorrhage with T inversion of the same. Osborne waves is also has been asked in some of the clinical scenarios. Hypo and hyperkalemia changes are very often asked. What is the first finding? What happens at the potassium level of so and so? So one or the other times, this ECG is again this one photograph from both the textbook clearly is one that scores on high yield topic. Let's go to cath tracings. That's the other thing that's very often asked. So cath tracings, it's looking at the tracing here. This is a case classical of mitral stenosis. So you look at this area. This is the gradient between the two waveforms. This is the gradient. So the pressure here is the wedge pressure, and this is LV end diastolic pressure. So this much is the pressure difference between the LV end diastolic pressure and the LA pressure. So there is a presence of end diastolic gradient, which is classical feature of mitral stenosis. So normally at the end of diastole, there should be no pressure difference between LA and LV, because you cannot directly measure LA unless you do a septal puncture, which you do in balloon mitral valvotomy. You usually measure the pulmonary capillary wedge pressure. So you float the balloon into the PA, hook and occlude it into a pulmonary arterial branch to get the venous pressure on the pulmonary venous side, which is pulmonary capillary wedge pressure, which will then reflect LA pressure. So if there is a gradient, if there is a pressure difference between the LA pressure and LV end diastolic pressure, it would represent mitral stenosis. There should be no gradient between LA pressure and LV pressure. So at the end of diastole. So that is a feature of mitral stenosis. So increased pressure in LA, it improves diastolic flow to the LV, LA, and increased wedge may lead to pulmonary edema, as we know. And this gradient is what you actually chase to take care of. So this is mitral stenosis and a diastolic gradient between pulmonary arterial wedge pressure and the LV end diastolic pressure. A lot of times they have asked you about cath tracings, where they look at the gradient between two arterial waveforms, and then you've been asked to differentiate between supravalvular, valvular, and infravalvular. Supravalvular, infravalvular, and valvular AS. So between the three of them, there are cath tracings to which I'll show you. But remember, there is a delay in occurrence of the waveforms of LV and aorta. So this is the, as you can see, this here, this line here, sorry, this line here is representing the LV pressure. And this line here, the other one that I'm drawing now, is your aortic pressure. Between the two, you can see that the aortic pressure actually, because of the elastic recoil, precedes the, here, you can see it precedes the LV pressure. And this difference, the gradient that you see on top to top, is the peak gradient, while the area difference between them represents the mean gradient. So peak to peak gradient is something that you often follow in cath, but that's not the classical way of looking at a gradient. You need to look at the same point of time, but that's not the question that's often asked. Often what they ask you is what is the gradient or what is the disease here. And you can see that aortic pressure from the diastole, you can make out that's aorta. From diastole being low, here you can make out this is LV. So if they are not even mentioning the chambers and there is a pullback, then you know that you're dealing with a case of aortic stenosis. AR, the classical feature is what is called as diastasis, which is rapid in aortic fall, acute aortic regurgitation. The LV and diastolic pressure rises very quickly because LV is not prepared to deal with the increasing regurgitation, and this leads to what is called acute diastasis wave. And this is how you differentiate acute AR. Very rarely this is asked. Another common difference that is asked, and this is a very important table. How do you differentiate clinical features between tamponade constriction, RCMP, RVMI, and effusive constrictive pericarditis? Go through this table. This is a very important table. Go through what is 3 plus. So, for example, prominent X descent is not there in patients with RVMI because of rise in the RVEDP. So prominent X descent may not be there in RV dysfunction. It's not there. Compare this with, for example, prominent Y descent, which is a feature of constrictive pericarditis. So just learn what is the diagnostic and which is not present in most of them. RCMP will have S3, pericardial knock will be there in constriction. JVP, pulsus paradoxus, as we told you, is a feature of tamponade, so is the X descent. So if you know, as I told you, if remember X descent for tamponade, Y descent for constriction, paradoxus for tamponade, not so much for constrictive pericarditis, but in effusive constricted, you will get pulsus paradoxus. Low voltage, you'll get in fluid, electrical alternance, you'll get in fluid, thickened pericardium, calcification, you'll get in constrictive pericarditis. RV will be enlarged in RVMI, and CT and MR can pick up most of the disorders. Another classification very often asked is the antiarrhythmic classification, which you should, as you know, is called as Vaughan-Williams classification. Quinidine is class 1. Flecainamide, propafenone, all are the same. But what they usually ask is this part. Some of the questions are popped up from this part. What other common action or side effects do they have? For example, quinidine has anticholinergic action. So it can cause side effects like retention of urine, it can cause dryness of mouth, etc. Can flecainamide, as we know, is used in as a pill in pocket, but it can itself be responsible in a structurally abnormal heart to trigger a VT. And as you know, in CAST trial, the molecule had failed, and that's the reason that it should not be used in CAST trial. We know it had failed with increased sudden cardiac death. It reduces arrhythmic burden but increases sudden cardiac death. Propafenone, remember, has got some mild beta blocker activity, though it's class 1 and has got some class 2 action. Amiodarone is class 3 but has again some action on 1 and some action on 2. It has got multi-organ toxicity. You should be aware of the toxicity of the same. Sotalol is one beta blocker that has got some amount of activity as class 3 as well. Dofetilide causes prolongation at slower of QT at slower heart rates. Dronedarone is pretty safe, but again, it's failed compared to amiodarone in long-term efficacy in trials. Abutolide is used only in acute conversion, especially in post-CABG or post-cardiotomy patients with atrial fibrillation. That's one indication you must remember. Ranolazine has got late sodium channel. It's also categorized as beyond the 4 classes. Lignocaine is used in reperfusion arrhythmia, especially in patients with ischemic. You may know class 1A, B, and C also. This is another slide which is slightly modified now for the lemon AC neuropathy in the new edition, and now it's become class 1. That's one change. So in the older edition, I've kept slide deliberately from older edition because this is what you guys must have read, and that it was a class 2A in pacing indication. Lemon AC type of cardiomyopathy or neuromuscular disease was associated and has been associated with pacemaker indication as a class 2. But now in the new guidelines and even in the new Harrison, it's mentioned as class 1. So remember, this is what has changed in new Harrison. I hope you've gone through the video on old versus new Harrison changes. Exhaustive video I've made and it's available on the app. You can just go through it. It'll help you to update the concept that you intend to look into. Uh, there is also, if you look at first degree AV block, it's only when the patient has got no symptom and still has got lemon cardiomyopathy, you can do it. Same is the case with the Mobitz type 1. So symptomatic, asymptomatic, you can choose. Another one is this table, which looks into the classification of various supraventricular tachyarrhythmias. So anything that comes uh, with a stimulant or otherwise from an exogenous pathological supraventricular tachycardia would include those arising from the atrium, inappropriate sinus tachycardia, focal atrial tachycardia, atrial flutter, macroentry, and atrial arrhythmia, also atrial fibrillation, multifocal tachycardias, AV node reentry, orthodomic AVNRT, or pre-excited tachycardias. You should know over their classification. Very important table here is mentioned about looking at how do you differentiate between various types of them. So just look at the A response. A lot of questions have been asked about AV response. How many A waves and how many P waves and how many QRS complexes you are able to look at. So that is the AV concordance that you're looking at. So are A and V depolarizations, which are representative of the inverted P or the upright P, which we may look at, or submerged P's, which may be evident only as the as you call a pseudo S. If you look at them, if it's 1:1, then the arrhythmias that are present include ABNRT or AT or even rarely atrial flutter. But if they are irregular, you know them as atrial fibrillation. AV blocks, if they are present and there are more A's than V, then you call atrial flutter, atrial tachycardia, rarely AVNRT with 2:1 block. If it's below the his bundle, VA block where V's are more than A, then it's of course a junctional tachycardia. This is another one as to now we have new therapies emerging for ablation of atrial fibrillation. I've covered that in my videos. But symptomatic AF, paroxysmal AF, persistent AF, permanent AF, those definitions you should know. Remember whom to ablate. So you may be asked whom to ablate. In that strategy, you probably need to remember if the patient is failed to drugs or if the patient has patient choice where antiarrhythmics is something that patient is not willing to take. So those are the two groups, especially in patients if they are not having persistent or permanent AF. Because in paroxysmal persistent AF, if there is heart failure, that's only group where you will consider ablation. Because otherwise recurrences are pretty more. It's only in the middle subgroup that the indication is probably the best. That's where it's class 1, if you can see. Failed drug therapy, persistent AF without major risk factor and high AF recurrences. So when drugs are given, drugs have failed, patient has symptoms happening in between. That's when probably the atrial myocardial substrate is not so bad that recurrence may be not so common. So you want to ablate where the recurrences are less. If you ablate a permanent AF, uh, it's going to very high chance that it's going to recur. So you do that only if there is patient in heart failure. That's why in such these subgroup it's class 2A in failed therapy if the patient is having its own choice. Catheter ablation if it's performed as a class 1 in a paroxysmal if the patient is having heart failure. So the only two indications are class 1. Others are not class 2. Are class 2 or A or 2B. So remember class 1 indication paroxysmal or persistent AF with not permanent AF with heart failure with reduced ejection fraction. That's one. And persistent AF without risk factor, where there's recurrence and drug has failed despite antiarrhythmics, that's the other group where you would do it. Now, VT versus SVT aberrancy, there are two algorithms, Verakai algorithm and Brugada's algorithm. You, I'm sure, have gone through that pretty much. So, AV dissociation, if it's present or absent, if it's present, it's VT. AVR criteria, which is usually purely based, if you are looking at a criteria purely based on AVR lead only, that's Verakai algorithm. But Brugada merges the same. If you can see, AVR is equal to primarily R or RS pattern, which is predominantly positive AVR, it's a VT. And the third criteria is the no monomorphic or concordant pattern, as we call single type of V1 to V6. That is either all negative or all positive, which is concordant pattern. Again, it goes on to suggest VT. So based on these three important criteria, AV dissociation, AVR, and discordant or concordance, you can actually pick out whether the patient is having VT or not. This is Brugada algorithm of diagnosing the same. Verakai algorithm is purely the AVR algorithm, which is used, but you can stick to this algorithm. This is pretty much what is expected from you. This was the table I was trying to mention and cover, that sometimes this may be too exhaustive for a lot of students to remember. So RVOTVT, LBBB pattern, because anything that comes from a right side will have left bundle branch block. That comes from the left side comes with the right bundle branch block. Now, if it's coming from above, it will be directed inferiorly. So from the outflow track, if it is coming, it will have 2,3 AVF positive. That's how you know it's a RVOT. So LBBB versus RBBB, that's what you first find out from the outflow track. RVOT, it will be LBBB pattern in V1 with inferior tall QRS in inferior leads and late transition in the precordial leads. While LVOTVT, again, it's 2,3 AVF positive, but early transition with R waves in mid precordial lead. So you get early transition means you get positive waves in V1, V2, V3, V2, V3. You know that it's from the LVOT. Fascicular VT, they typically are RBBB VT. In V1, you will get RBBB, but there is an intrinsic deflection. And also there is a left axis because they arise from the posticular fascicles most commonly. So if you have RBBB morphology and you're dealing with a intrinsic deflection, RBBB with some notching in between, then you know this intrinsic deflection is part of a fascicular VT. And remember, fascicular VTs are narrower compared to outflow tract VTs. Same is the case with papillary muscle, where again you get RBBB pattern in V1 with R waves in left axis deviation. So if they come from the posteromedial papillary muscle, that's how they will have left axis. Anterolateral, again RBBB, V1 with positive deflection in lead 3 and negative in V1 because it's from the anterior, so it will go posteriorly. It's anterior papillary muscle, go posteriorly. So posteriorly, you'll get positive deflection in lead 3, while it is away from the V1, so it will give negative V1 in the anterolateral. The reverse is be the case with the posteromedial one. Monomorphic VT, polymorphic VT, everybody knows. Arrhythmogenic RV dysplasia, you know about the epsilon waves. Tetralogy, you can get RVOT-VT with V1 and morphology of LBBB morphology because it's coming from the RVOT. You should look out for torsades. There might be some of the ECGs. So these are the causes of long QT. You should again know the drugs that can cause it. So class 1, class 3 are notoriously known for that. And so are a lot of antibiotics. So macrolides, quinolones, sulfamethoxazole, trimethoprim combination, clindamycin, pentamidine, etc. Antipsychotics are the other notorious group. You should know other causes of the same. When you get a patient of storm, how do you manage? That's the other algorithm that you should know. So you stabilize either with defibrillation, amiodarone, or lignocaine. That's rapid. And if it works fine, otherwise you go to quinidine, ranolazine, and procainamide and catheter ablation. But very important, address the triggers. Stabilize the rhythm, address the triggers, and reduce the sympathetic drive. So here comes one important aspect, which is stellate ganglion blockage. And also you need to rest the ventricle. So you may put on ECMO, especially in patients with ischemic one and cardiac surgical denervation in such cases. Electrical storm, definition of more than 3 episodes in 24 hours of ETVF is what was given in the old edition, and that's what we'll stick to for the exam purposes. Monomorphic and polymorphic, you identify the cause. Monomorphic, the drug of choice would of course be beta blocker, amiodarone, lignocaine sedation. Long QT, electrolyte repletion, magnesium pacing, isoproterenol, lignocaine, and SBG. Normal QT, you skip the electrolyte aspect. Just look at beta blocker, amiodarone, and lignocaine. PVC based, again, pretty much the Brugada, remember. You need to think of quinidine and calcium channel blocker. Isoproterenol is the other choice, and catheter ablation. Inflammation, it's steroids and amiodarone and ganglion blockade. This is the tracing I was talking about. So there may not be two tracings to look out. There might be just a pull-out tracing. So you have a single pigtail which has been inserted in from the LV, it's being pulled out. So how do you differentiate that from what type of etiology or obstruction you're dealing with? If you look at the pressures of the peak here and the aorta. So the where is the pressure falling? That's how you identify. So when you are in the LV, you came out from the LV and reached the aorta. Here, the diastolic has increased, means now you are in the aorta, you're no more in the LV. But has the pressure, systolic pressure changed? No, it has not changed. So systolic pressure is same, even though you've come from the LV to aorta. But what happens as you go beyond in the aorta, the systolic pressure falls. Why would that happen with diastolic not changing? Because there is obstruction above the aorta, aortic valve, which means it's a supravalvular. Valvular, as I told you, as soon as you come out from the LV to aorta, the systolic pressure falls. So this is valvular AS. And compare this with subvalvular, again, pretty much understandable that if you are still in the LV, your diastolics are still zero, but there is a difference between peak to peak, though diastolic has not changed, but there is a difference from systolic pressure within the LV cavity. So there is a difference between systolic pressure within the LV cavity. This means it's a subvalvular aortic stenosis or HOCM, as you can say. So you may not always get a cath tracing of, say, uh, uh, the Brunwald-Brockenberg phenomena or two pigtails. You may get just one tracing and pulling it out. You need to go through it. Just go through the videos on spotters that I've done. I'll share that link also in the group. Go through that video. It is one that will give you practically almost all tracings in one place. Absolute contraindication of TMT has been asked multiple times in the exam. MI within 2 days, high risk unstable angina, uncontrolled arrhythmia, endocarditis, symptomatic severe AS, not asymptomatic. Remember, this is very often the option. They mention asymptomatic AS where it's not an absolute contraindication. Decompensated heart failure, acute pulmonary embolism, acute myocarditis, and of course, inability to do it. A lot of times a Duke treadmill score is asked. Anything at high risk would be minus 11 or less. So anything less than minus 11 would be qualifying as high risk. Anything between more than this, which is would qualify as intermediate risk. Anything plus 4 is called as low risk. So plus 5 is one cutoff, minus 11 is the other cutoff. So if the Duke treadmill score is more than 5, 97% 5-year survival, minus 11, 72% survival. You should know the normal values of a lot of things. So this again you can do on the last day. What is the normal mean RA? What is the peak mean SVR value, PVR value? What is mean AV oxygen difference? So this is something that oxygen consumption index. These values you should know. So remember, mean of RA is 0 to 5. Mean RV pressure end diastolic is 1 to 7. And PA pressure, remember now we know the definition, mean has to be not more than 20. So 9 by 19. Wedge is between 4 to 12. LA is between 4 to 12 as well, because there should be no gradient. Otherwise, that's an obstruction that you find. So 4 to 12 is an easy number on the left side to remember. Uh, uh, Pressures, of course, aorta LV, you know. Uh, Resistance SVR is 900 to 1400 and PVR is 40 to 120. How do you convert it into wood units? The other unit that is used is wood units, and the wood units you divide it by 80. So when you divide this number by 80, you will get the answer in wood units. So this is SI units. Wood units can be converted by dividing this by 80. Oxygen consumption, AV oxygen difference normally is 3.5 to 4.8, while oxygen consumption is 115 to 140 liters per minute per meter square. In patients undergoing PCI, how long to give DAPT? Remember, simple thing, it's 3 to 6 months, ideally less than 3 months. If there is harm, if there is delay, then you can actually take it off. But ideally, 3 to 6 months, up to 6 months is one. That's where you would consider. If surgery is beyond 6 months, you can surely discontinue the same. So, a patient who's got a PCI and undergoes a surgery, if it's less than 3 months since DS implantation, there you can try if you can delay the surgery. But if it's between 3 to 6 months, proceeding surgery you can consider. But if more than 6 months, you can surely discontinue DAPT. Again, it depends a lot on what kind of stent you've used. There are certain stents which have been studied in this kind of a scenario, like master DAPT trial, where the discontinuation was done at 1 month, and it showed that in certain stents it was pretty much okay. A patient who is scheduled for surgery with known CAD risk factor, you need to define whether it's an emergency surgery or not, whether the patient has ACS or not, estimate their preoperative risk for MACE. If it's a low risk, you can go ahead and proceed. If it's moderate or greater risk, look whether you can do a functional assessment, do a treadmill that is, which is more than 4 minutes. If it's good, he can do it, say 10 minutes of 9 minutes of exercise, which is roughly more than 10 minutes. You don't need any further testing. But between the two, you probably still proceed, but it would be low risk. But if the patient can't do even 4 minutes of exercise, you will have to do a pharmacological stress test. And if anything is abnormal, you'll have to do a coronary angiogram. So this is how you decide for a CAD, which is occult or suspected in a patient with undergoing a surgery. Drug of choice in hypertensive emergency is very often asked on a beautiful table. Hypertensive encephalopathy go through nitroprusside, nicardipine, and labetalol. Stroke, it's nicardipine, labetalol, and nitroprusside. Infarction, again, nitroglycerin, nicardipine, labetalol, and esmolol. Acute LVF, again, nitroglycerin and alloprolate or IV diuretics. Very often they ask you about dissection. Drug of choice is nitroprusside with labetalol. So, don't think of phentolamine, etc. here. Adrenergic crisis is where you choose phentolamine and nitroprusside in adrenergic crisis, as in pheochromocytoma. Post-operative hypertension, nitroglycerin, nitroprusside, labetalol are the other choices, the drugs. Difference between stunned myocardium and hibernating myocardium. Remember, recovery days to weeks in stunned myocardium. That's where transient post-ischemic LV dysfunction is there. Repetitive episodes will lead to stunning or will lead to hibernating myocardium, where the revascularization can lead to eventual recovery. Stunned is alive but not and perfused. Hibernating is alive but not perfused. So if you improve perfusion, you can combine PET with SPECT to pick up and differentiate stunned versus the two. Another common thing that is asked is type of myocardial infarction. You should go through this. MI related, very often the questions have been asked. PCI related MI, which is type 4A, bypass related, which is type 5, MI, procedure related MI less than 48 hours would defined as more than 5 times the troponin. Type 4 MI A is more than 10 times. For type 5, it is post CABG, it is 10 times the rise of the 99 percentile of the troponin value. So, this is another way. Other is type 4B, which is stent thrombosis, type 4C, which is restenosis of type 1, but no thrombosis. So, that's how you differentiate 1A, 4A, 4B, and 4C. 4A is immediate post PCI. 4B is stent thrombosis, 4C is restenosis. And of course, type 1 and type 2, which are very commonly known. Newer drugs, newer lipid-lowering drugs. Again, go through this table with which drugs acts. Like B100, it's mipomersen. MTP, that's lamitopide. Uh, Sebelipase is a lysosomal lipase inhibitor. You have peptides coming in recently. PCSK9 inhibitors have also entered market. Nopidamate is also MTP inhibitor. Pregidastat is the other drug. Uh, 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 Volani is another drug which acts at ApoC3. You have evenirikimab, which acts at NPTL3. Remember, yesterday only, they've done the CRISPR gene editing of NPTL3 in the first time as a gene therapy for familial hypercholesterolemia FH patients in 15 phase 1 trial. And the trial came positive and published in American Heart Association in the abstract in the circulation recently yesterday. So PCSK9 is probably the target that they are looking at, but also they have looked at now with the published phase 1 data from NPTL3, CRISPR gene therapy for NPTL3 in patients with homozygous familial hypercholesterolemia phase 1 trial out. Management of stable CAD, very important. Remember, in stable CAD, indication of a procedure is documentation of ischemia on top of optimal medical therapy. So when you are giving full drugs, patient is still symptomatic and has another associated comorbidities, that's when you give. So initiate medical therapy, you need to do any high risk patient, low exercise capacity, EF less than 40. If yes, then refer for angiogram. If no, are there any exertional symptoms? Look for that. Once you've suspected, look at the functional capacity, adequacy of medical management, looking at the calcium score, document ischemia, perform a stress test. And if there are no confounding feature, if the stress test is normal, then probably you can think of medical management. Other way of looking at and identifying ischemia is doing a stress test or a nuclear scan or cardiac MR or a cardiac PET. Once the other way to look of a patient who comes with acute chest pain with ECG, not suggestive of STMI. If it's STMI, it's much easy. Otherwise, look at if it's looking non-ischemic, do a heart score. And in the heart score, if the score is less than 0 to 3 or up to 3, and troponin is negative, you can discharge the patient early. If it's more than 4, then you need to do cardiac reference. Otherwise, a troponin is something that can be adjusted in the outpatient department to stratify the patient. So once a patient has reached to you in an STMI, now there is enough data to tell you that you need to go early invasive strategy. If the patient is very high risk, you need to do within 2 hours, high risk within 24 hours. Otherwise, intermediate risk can wait up to 3 days. Low risk can always be deferred for later on. These are the important timelines that we know. First, medical contact to device time of less than 90 minutes, door in to door out time less than 30 minutes. You should transfer the patient from PCI to non-PCI to PCI center less than 122 minutes. administer the lytic agent within 30 minutes. Practically 2 hours, the upper window that you are expecting, and you don't want the difference between lysis and the invasive strategy to be more than 90 minutes. That's the crux of the story. The primary prevention of sudden cardiac death in ischemic heart disease is another important aspect. If you look at the EF in patients, if it's less than 40, if its EMI is less than 40 days, if that's the case, you just optimize. You don't put an ICD unless you have a sustained inducible VT and EP. That's when you can do an ICD. Otherwise, if the preserved EF is there, improves, then the patient is out from the ICD program. Otherwise, if the patient is high risk and has an EF less than 30% or is class 2 and 3 and EF of less than 35, patient gets an ICD beyond 40 days. In patients who have more EF less than 40 and you can induce a VT or has an EP or has a non-sustained VT documented, that also patient gets an ICD. So heart failure programs need to be defined. There are various ratios. Remember a simple rule. FFR is the only way where the cutoff is 0.8. Rest all it's 0.9. That's how you roughly remember. FFR 0.8, all others 0.9. Non-hyperemic and hyperemic indices, whole cycle versus non-so whole cycle. So PDPA, RFR, DFR, IFR, DPR, all the systems RF are all 0.89. So anything up to equal to they have mentioned. Remember, it's equal to. So zero point 0.9 as a cutoff. And here it's 0.8. So FFR is 0.8. All other parameters, I'm not revising how the differences do exist. But if there are other criteria asked, then it's 0.9 or 0.89. That's how I remember. Very often they're asking efficacy of the most effective lytic agent. Look at the 90 minutes patency rates. It differs between the books, but you stick to your standard book. And the TIMI, because a lot of them have similar grades, you need to then look at the TIMI flow grades. So which is best for tenecteplase. So TIMI flow grades is best for tenecteplase. Mechanical complication, remember all of them happen between 3 to 5 days. Um, uh, Mortality, free wall rupture is 100%, the maximum. 90% for VSR, between 50 to 90, depending on how big the VSR and when you're operating. And papillary muscle rupture, 40 to 90 days. Incidence of all of them is 1 to 2%, but amongst them, the highest is free wall rupture, between 1 to 6%, with almost 100% mortality. Primary prevention in IHD, as I've already discussed this slide. What are the various assist devices? So you have Impella, Tandem Heart, ACMO, IBP, and Impella of various values. So you have right ventricular RP, then you have 2.5, 3.55, and then you have other devices like Tandem Heart from not RARV side, but left side also. So these can do it. Uh, Placement, all of them except the Tandem Heart, which is jugular, is for tandem heart, you put jugular, rest all will get femoral only. The cardiac output is represented by the number. Maximum cardiac output you can achieve by VA ECMO, which is 7 liters with maximum 5000 RPM. But remember, the sheath is 14 to 19 and 17 to 21 for venous. But compare this with tandem heart, which is 29 French. IBP, of course, you can put even 6 French. But Impella, you require 12 to 14 French. Unloading, depending on which chamber they're working on, that's how you would know. This is another classification of heart failure. Typical acute decompensation, pulmonary edema, low output, and cardiogenic shock are the 4 variants. Now they categorize it as wet and dry, volume loaded or not. That's the other classification. But this is the algorithm of what drugs to use. We know the 4 pillars of heart failure. Then sometimes people talk about 8 pillars where you had IVI and vericiguat, etc. Ivabradine, digoxin. Remember, DigitHF was the new trial published recently, which looked into digitoxin as the new therapy, which showed some promise for this old wine in new bottle. The digitoxin probably has some advantage over digitalis in the digit-HF. That's where the data is emerging now. Reduced ejection fraction. Remember, SGLT2 are the only ESC approved class 1 indication. ACC still classifies them as 2A, but actually all of them across the spectrum of heart failure, SGLT2 is the one that gets you the class 1 indication. So if you mark it as class 1, it's pretty fine. FPEF scores, that's the other thing. Sometimes it may be asked. It's now integrated in the new edition of book. So you should know H for heavy, H for hypertensive, A for AFib, pulmonary hypertension, elderly, and E by E prime. That's one score. and that can predict whether the patient has got heart failure with preserved ejection fraction. A score more than 5 would suggest it. But there are features like functional, morphologic, and biomarkers. Biomarkers, the NT-proBNP and BNP, are the most important one. Remember, the values are different if the patient has got AF or does not have an AF. The values do change. In AF, the cutoff is higher. One slide summarizing management strategy for sarcoid. You can take a snap of this. It covers everything. Once you've diagnosed the sarcoid, look whether the patient has got second or third degree AV block or a VT or EF less than 30. If that is present, you need to put an ICD. If none of them is there, consider an EP. If it's positive, put an ICD. Otherwise, it's negative, then you continue to evaluate the patient with medical therapy. So who do you put an ICD in a patient of cardiac sarcoid? These are the indications: documented high-grade AV block, VT, or patient with EF less than 30. So once you have suspected, you look at the arrhythmias, as I mentioned, look at the function, and then investigate in form of FDG PET or cardiac MR for LGE. Look at blood tests like ACE levels. You can even look at the soluble IR2 receptor, do a cardiac biopsy, rule out extracardiac granulomas that you may have in eye, lung, skin, lymph nodes, musculoskeletal, etc. And once the diagnosis is made, you need to treat it with appropriately with steroids. Another single slide, cardiac amyloid. Red flags, how do you pick? Low voltage. So what is called a pseudo-infarction pattern. The echo shows pseudo-infarction pattern. The echo shows thickened septum, which is looks like an LVH, but ECG shows loss of R waves. The ECG shows as if it's a gold MI. That is a classical feature of an echo. That's when you suspect. Any patient cannot tolerate beta blocker ACE inhibitor low dose, even diuretics low dose are again to be suspected to be having repeated hypertension, pulmonary edema, hypotension, edema. That's one subgroup. Macroglossia in AL type of amyloid, low blood pressure in patients previous of hypertension who now became hypertensive, carpal tunnel syndrome, spinal outlet syndromes or spinal compression, cord compression syndromes. AL, you get primarily nephrotic also. They will have macroglossia, orthostatic hypotension, neuropathy, and of course MGUS may be present. ATTR you typically get in white males with history of carpal tunnel. Usually carpal tunnel and spinal stenosis, they precede by a couple of years. African Americans can also present with the same without a history of hypertension, hypertrophic cardiomyopathy in elderly, low gradient, low flow aortic stenosis. That's where you should suspect ATTR type of amyloid. Once you suspect and a confirmed case of amyloid, look at the standard care of therapy that you otherwise give, the 4 pillars of heart failure: beta blockers, ACE, ARB, ARNI, MRA, and SGLT2. Once you've done that, look at the disease modifying agents that are available. ATTR amyloid, you can choose tafamidis, and now you have newer generation of inhibitors of the formation of the linkages between the amyloid chains. So apart from that, the ATTR wild variant and the mutant variant, you can think of inotersen, patisiran, tafamidis, etc. Apart in patient has got both cardio and neuropathy involvement. Otherwise, do treat them for DOACs for atrial fibrillation. They present it very often with it, and a lot of them may require pacemaker on ICD or CRT in selected cases. Coming to an image, quick revision, I'm going to take you through. This, remember, is an atrial flutter. So don't be misled that you're dealing with a case of flutter with variable block. This is not complete heart block if you may suspect them to be P waves. But remember, the P wave will never be present in some leads, absent in the other. It has to be discernible. Look at the rhythm strip. You can see multiple sawtooth appearance, and that's why this is a case of flutter with variable block. Brugada and Veracay algorithm I've already discussed to you. RS complex, R by S interval, AV dissociation, and morphology is what is Brugada. AV dissociation, R or AVR criteria, as we call QRS morphology, and the intrinsicoid ratio, IT by VT of less than 1, are the completion of Veracay algorithm. But you can stick to Brunwald's combination of the two algorithms that I discussed already in the previous slide. How do you differentiate VT from SVT aberrancy? But if you want to know the two algorithms separately, Veracay, remember, is primarily AVR driven algorithm. It relies heavily on that apart from the AV dissociation. Coming to this is what you mean by intrinsicoid deflection. A lot of students had text me. This is the deflection that you're looking at. This duration of beginning of the complex to the depth, the peak to nadir. duration. So if this duration is more than one small square, that is 30 milliseconds, you will consider it as a VT. If there is slurring of the downslope, it is a VT. And if the duration, intrinsic duration is more than 70 milliseconds, you consider that as VT. This is another ECG. This narrow QRS complex, don't be misled that you're probably dealing with a case of sinus rhythm. You need to wind your P's. P's are discernible different from QRS complexes. They are migrating through the QRS complexes. There is no association. Actually, it's AV dissociation. It's a genital complete heart block. AV nodal maneuvers, a lot of times you may be asked what happens when you give adenosine or what happens when you give vagal maneuvers. No effect in fascicular VT or inadequate dose. Slows down in sinus tachycardia and junctional tachycardia. Termination, only AV nodal dependent pathways. So you get AVNRT or AVRT or adenosine sensitive focal AT. And atrial rate continues, but AV block appears, then it's atrial flutter or ablation. This is saddleback type and the cove type of ST elevation that you get classically as a shark fin appearance in type 1 Brugada. That's the classical diagnostic. These are non-diagnostic features of the same. So in Brugada patient, if there is symptomatic and aborted patient of sudden death, you must put an ICD. So should you do that in a case who had a unexplained syncope and the spontaneous type 1 pattern you're seeing, or if that is triggered after a sodium channel blocker, then you can consider ICD. But in asymptomatic patient, if the patient does not have spontaneous type 1 ECG, you don't consider the same. You can just do a follow-up, especially if the EP study is negative. You cannot induce a VT. Also, you must consider family history. If there is no family history, again, you can just do a close follow-up. So all you need is classical type 1 pattern, history of sudden cardiac death, family history, or inducible VT. These are the four things. If they are present, you think of an ICD in Brugada. This image is very often asked. It's an image of ARVC. Just think of that image, fibrofatty infiltration and replacement that happens in patients with ARVD, and they present with epsilon wave. This is a typical epsilon wave. ECG shows an RBBB pattern, reproducible amplitude with QRS complex, which is characteristic of ARVC. Tumors, commonest tumor is the question that is asked. Adults, myxoma. Children, rhabdomyoma, and infants, also rhabdomyoma. So commonest benign tumor, myxoma in adults, rhabdomyoma in children and infants. That's what you should remember. Hemodynamics I've already discussed. So just summarizing that again for you. Constrictive pericarditis pulsus paradoxus happens in 1/3, less than that, but tamponade it's very common. It's rare in other disorders. Same prominent X descent I told you, tamponade, prominent Y descent in constriction. But very important, square root sign is present only in patients with constriction and RV infarct. This is another very classical photograph that is given and asked in exams. You can see the concordant and discordant LV-RV pressure. So if there is ventricular interdependence, which means when the one pressure rises, the other falls. That's a feature of discordance. So as you can see, the pressure here is falling for the LV. What is happening to RV? It is rising. It's rising. So both are in different direction. Again, you can see with the arrow marked here that it's when the LV pressure is going down, RV pressure is going up. So they are moving in different direction as through the respiration. And hence this discordance because of ventricular interdependence is a feature of constrictive pericarditis. So if you look at RCMP, the respiratory changes would be there, but they are concordant. They move in the same direction. As the LV pressure rises, so does the RV pressure. Maneuvers, dynamic auscultation. Remember one simple rule, all murmurs decrease except HOCM and MVP on standing in Valsalva. One line and everything is you can remember on the last moment. Of course, the mechanism is the LV preload and afterload, LV size, volume of the LV depending on the amount of flow that you get because of whenever there is increasing in the preload, LV dilates, so less obstruction, so decreasing the murmur of HOCM. Same is the case with MVP. Also, when the systemic vascular resistance, peripheral vascular resistance is high, as in squat, the resistance is more, LV becomes more dilated, obstruction decreases. So that's the mechanism, but you can just remember it as in a one-line dictum. All murmurs decrease except HOCM, MVP, and Valsalva and standing. So this is Grunwald-Brockenbrough sign. Everybody knows that. Narrowing of pulse pressure more than dynamic nature of obstruction, the obstruction increases more than the pressure rises itself, and hence there will be fall in the aortic pressure as compared to the LV pressure rising in that scenario. Mavacamtan, two trials, Pioneer HCM and Explorer HCM. You should know it reduces the gradient, improves the quality of life. Infective endocarditis, streptoviridans, community acquired is the commonest cause. In healthcare, it is MRSA. In IV drug abusers, it's Staph aureus. Staph aureus leads to pathogenic in early prosthetic valve endocarditis. One third of 35% and one fourth of them are MRSA. Lead prosthetic, it's like less by Staph, and it's more common. High occurrence is by Streptococcus galolyticus. Negative blood culture, infective endocarditis, you should suspect fastidious organism. Look out for in ICE PCS study, antibiotic therapy given within 7 days is one of the commonest cause that's given in Brunwald as the responsible cause for a negative one. Drug side effects, drugs in cardiology, cardio-oncology, which can cause heart failure, anthracycline, we all know, but they may be asking you about trastuzumab, bevacizumab, imatinib, dasatinib, and sunitinib. Ischemia caused by 5-fluorouracil, capecitabine, paclitaxel, docetaxel, even cisplatin and thalidomide. Hypertension, bevacizumab, sunitinib, sorafenib, and cisplatin. Tamponade, busulfan, and hemorrhagic myocarditis by cyclophosphamide. Brary arrhythmia can happen with paclitaxel. Raynaud's is caused by vinblastine and bleomycin. QT prolongation by arsenic, and venous thrombosis by cisplatin and thalidomide. This is the flowchart for TAVR indications. I think you all have gone through. Remember, now it's updated. Now it's no more 65, it's now more than 70. Remember this, this is one update. Now the answer would be 70. You can always challenge if somebody tells you the new guidelines have been updated. The age cutoff for choosing TAVR is 70 for class 1 indication. AR, remember rule of 3, 4, 5, 6, I say 3 is ERO of 3.3 centimeter square. 4 the 5 is your 50% of regurgitant fraction, 6 is your vena contracta of 6 or RV regurgitant volume of 60 ml, and these 4 numbers are what we are talking about. So 4 numbers and 3, 5 and 6, 6. So 3, 4, 5, 6. That's how you can roughly remember as a severe AR. So once you have symptomatic, you of course operate. Asymptomatic has any complication, which means if there is LV dysfunction, is undergoing some other surgery, its LV is dilated, its end systolic dimension more than 50 or more than index more than 50, 25, progressive changes, and then also you suggest the patient to undergo the same. Severe MS, symptomatic, do a BMV. Severe MS is 1.5 now. PH, atrial fibrillation are the other two criteria, but it's no more class 1 indication. Carpentier classification, again something asked. Type 1 is normal leaflet. Mechanism is ischemic dilated cardiomyopathy, where there is annular dilatation, deformation, leaflet left, cleft. Also, if you have type 2, which is basically increased leaflet prolapse. So they myxomatous degeneration like Marfan syndrome or Barlow syndrome, in rheumatic endocarditis, trauma, ischemic cardiomyopathy, Ehlers loss will qualify as type 2. While type 3 is restricted motion. So these you get in carcinoid and rheumatic or ergotamine SLE. Type 3B is restricted closure also, apart from restricted opening. So opening is A, closure is B. So closure is restricted in patients with DCMP and ICMP. MR, again, same criteria, 4, 5, 6, 7. 4 is 0.4 of ERO, 5 is 50% RF, volume 60, and vena contracta of 0.7. So once you define that, any patient who's got symptomatic or has got LV diastolic dysfunction with dilatation are the one that undergo surgery. Secondary MR versus primary MR guidelines are slightly different. In secondary MR, they don't consider value of vena contracta. They are considering only RV volume, RV fraction, and ERO, and look at the LV dysfunction. If LV dysfunction is there, then you must look at the anatomy, which is favorable. Remember, edge repair or TEER as we call is done if EF is between 20 to 50%. LV and systolic dimension is less than 70 and pulmonary pressure is also less than 70. These are the criteria which must qualify for patients to undergo edge repair. TR at the time of some mitral surgery or aortic surgery, if there is severe TR, you need to operate. Otherwise, you look out for right heart failure, primary TR. If it's there, it's a 2A indication. Secondary TR, post GDMT, it's dilated, annulus more than 40. That's when you consider. Otherwise, in patients who are asymptomatic, primary TR with progressive RV, it's 2B indication. Progression of TR, you should always try to do medical management first. pH, this is very important and common slide, very often asked. Look at the right heart cath, measure the mean pressure. Remember the definition of pH is mean PA pressure more than 20. Look at the PVR and look at the wedge. That's how you categorize them as to what type of WHO pH group you fall into. So a patient who's got a PVR high and wedge less than 15. So PVR is high, wedge is low, it's class 1. PVR is high, wedge is high, it's class 2. PVR is high, wedge is low, and the patient has got obstructive lung disease, it's 3. It's low, and patient has got prior pre-EC, it's CTAP, and if there is comorbidity, it's rare subtype. So thank you very much. That brings us to the end of this session. I hope it was worthy for you to understand the important concepts. Very importantly, quickly summarizing, what I'm going to tell you is that once you have revised, stay confident that you've whatever you've done, there's never going to be anything sufficient enough for all the topics to be covered. They are not going to ask you everything out of that. They're going to ask you selective ones. What important thing is that whatever you attempt to the best of your capacities. And for that, it's very important that you maintain your cool. In these 7 days, try to see a topic visually rather than listening to it. See the video or see the book. Just don't listen to it. The active learning should involve all five senses of yours. Try to revise the concept. Don't try to rush through new things. Give practice test every day at the time that you're supposed to give exam so that you're in physiologically in the loop, that it helps you to do it. As I told you, do a reverse approach. Prepare your own timetable. Do the conceptual question first. Don't do the rote memory based first, do them the last. Focus on high yield topics and practice daily. Give a lot of tests, do the question banks, do the quick revision, question based approach. That's where you probably will score more than anybody else. My best wishes are always with you. I've been interacting with you on WhatsApp. I'll continue to do the same and clear your queries. Stay connected. Best wishes. And I'm sure that you're going to rock and I'm going to take your interviews for the success interviews. Take care and bye bye. Good night.